Well, thank you for inviting us, and thank you for the opportunity today to share with you a project that we have been working on at the CDC known as EDEN, which stands for Enhancing Data-Driven Disease Detection in Newborns. The outline of our presentation today is as follows. We'll start with a quick background on newborn screening. Then we'll move on to an introduction of EDEN, followed by a deeper dive of the EDEN platform done by Amy Gaviglio. And then Amy will wrap up with the next steps and ongoing considerations in building a national newborn screening platform. Though we know that many of you are familiar with newborn screening, we wanted to provide some brief background on newborn screening itself to help understand why we have embarked on the creation of this national newborn screening data platform. Before we delve in, we want to ensure that we're all on the same page as to what newborn screening is. This schematic illustrates the process of newborn screening, whereby samples are collected from a population of newborns around 24 to 48 hours after birth. Using a dried blood spot or a filter paper matrix, a number of analytes are examined through various testing platforms. And these screening tests identify those newborns that are at high risk of having newborn screening diseases, as distinct from those who are at lower risk. The newborns identified as having a higher risk must then complete further testing, diagnostic testing, to determine whether the child is indeed affected or is a true positive, or whether the child is actually unaffected or a false positive. It is important not to forget about those infants who essentially pass through the screen with a low risk for disease as screen negatives, however, and while the vast majority will be truly unaffected or true negative results, there are some individuals or some infants who may actually be affected and thus have a false negative screening result. While the previous slide seems relatively simple, it is actually much more complex when we start asking questions like, what does it really mean to be affected? And how and when will we know that? When it comes to a wide-ranging disease spectrum and diseases with later onset variants. These 4 points are really the crux of newborn screening and has helped to explain why a national newborn screening data platform is so very important. The first is that newborn screening programs are state-based, which means that discrepancies will exist across programs in a number of ways. The second is that newborn screening programs are typically opt-out programs, which means that nearly all 3.8 million babies born in the US do receive newborn screening unless the family chooses to refuse newborn screening on behalf of their infant. Not surprisingly, screening so many individuals on an annual basis generates an immense amount of data, and this data in aggregate can be used to assess better ways to detect affected newborns, identify new and better ways to screen using novel biomarkers, and evaluate the impact of newborn screening on health outcomes. As many of us know, newborn screening disease panels continue to expand both in terms of quantity of diseases, but also in the complexity of the testing and analytics. And this evolution itself lends itself to the need to improve data analysis, aggregation, and interpretation of the results. All of this taken together led our program at the CDC, the Newborn Screening and Molecular Biology branch, to develop a 10-year long-term vision and mission that was focused on modernizing practices within the newborn screening community, focusing on enhanced data use and analysis. So in general, what is the EDEN data platform? To address both the increasing number of diseases on newborn screening panels, as well as the growing technological and interpretative complexity, we're working on the development of a national newborn screening data platform known as EDEN. EDEN, as I mentioned earlier, stands for Enhancing Data-Driven Disease Detection in Newborns. And this work aims to use nationally harmonized and aggregated data in combination with advanced analytics to improve the detection of those newborns who are at risk for conditions screened for through newborn screening. By making a platform like this available to all state programs, we expect to see a decrease in disparities across screening performance metrics, which will ultimately improve family experiences with newborn screening itself. The idea behind EDEN is not new. Discussions with state programs around the utility of a platform like this actually began nearly 5 years ago. And it also led to a meeting that we had in 2019 that was focused around a national data analytics. At this meeting, newborn screening programs were led through a series of discussions and questions and exercises on the need for and the potential development of a national data platform. Here we present some of the key findings from that meeting, which indicated that newborn screening programs were not only supportive of, but really have been pushing for a national newborn screening tool to aid in their own efforts within their programs. And this slide is a very high-level schematic of EDEN. We will be collecting 3 primary sets of data, biochemical data, molecular and clinical data, in addition to general demographic data as well. We intend for this data to be transferred to EDEN using standard messaging protocols and standard vocabulary. Once in EDEN, the data will be processed and analyzed in near real time so that it can be utilized to make decision or result determinations with the ultimate goal of improving risk assessment and clinical decision-making in newborn screening.
All right, thank you so much, Carla. And so now that you have an understanding of the impetus for EDEN and the overarching concept, in my part of the talk, we'll take some time to kind of dive into the EDEN project a bit deeper. So I'm not going to spend too much time on this slide except to illustrate really the iterative development process that we're using for EDEN. So we start with what we call a proof of concept. This is developed using requirements from the newborn screening community. We use those requirements to then build a prototype. And once the prototype is up and working, we go through several rounds of pilot testing and kind of further development and modification prior to our ability to go into production, which we have not done at this time yet. So we're really right now focused on the prototype and pilot phases. And I do want to mention that during those phases, only mock or synthetic data is being utilized. EDEN is being developed currently in the CDC cloud. And again, as Carla mentioned, the dynamic nature of newborn screening, really understanding that newborn screening continues to evolve. We are really focused on flexibility and scalability of this data platform, while of course also ensuring high levels of data security and privacy, especially for when we do begin to collect real patient data. So there are a number of ways that EDEN will be able to be utilized by newborn screening programs, and this is just an example of kind of how data might flow between newborn screening programs in EDEN. So ideally through linkages to the newborn screening program, their laboratory information management system or LIMS system, data will flow over to EDEN and will be processed through machine learning algorithms, at least in the case of biochemical data. And then the risk decision support will be provided and sent back to the newborn screening program LIMS. This information would then be incorporated by the newborn screening program and utilized to generate a final result report. For any actionable newborn screening results, so those results that either need repeat screens or are referred clinically, newborn or Eden will also work to collect diagnostic outcome data so that we can help ensure clinical validity of the tool and provide better understanding of the diseases being screened for. And so as you can see, for programs to really be able to utilize this as part of their high throughput workflow, we will certainly need robust data transfer and processing capabilities, which I will talk about a bit later. So this slide indicates our current technology stack, which again, I'm not going to spend too much time on except to highlight a couple of things. So you can see we're using a number of different technologies. We are currently in the AWS Gov Cloud, but we are looking to potentially migrate over to Microsoft Azure. So we are able really to better utilize some of the data analytics features within Azure and of course align with CDC's data modernization initiative. We're also going to be using, if you go all the way down to the bottom, the CDC SAMS, which stands for Secure Access Management Services Platform. This is how users will access Eden, and this will provide user authentication, and will also be able to provide role-based access. So as Carla mentioned earlier on, Eden will encompass 3 primary data modules covering biochemical, molecular, and clinical data, and we'll delve into each of these in a bit more detail on the following slides. So challenges identified in the biochemical newborn screening space are really likely not new to many of you, and they include things like the variability between programs in cutoff determinations, the difficulty in screening for really rare diseases where programs, and especially smaller programs, may not see an affected newborn for years, which makes optimizing sensitivity and specificity of those screens very difficult. The biochemical module is still, very much in its, I would say, infancy in development, but we've been putting forth a big push this year on this module. So we've been convening small discussion groups for discussion on various ways to harmonize analyte values coming in from different laboratories using different testing methods, and also assessing possible machine learning and other analytical solutions that can improve our ability to provide accurate risk assessment. Really during this time, as we're honing in on the biochemical module, we're focused on learning from and building upon existing projects and in work surrounding biochemical data algorithms. If we move on to the molecular module, so this by far is the furthest along in development right now. This image illustrates challenges identified by the newborn screening community and subsequently proposed solutions that will be provided for by Eden. So here identified challenges include the relatively high rate of variant findings, and especially variant of uncertain significance findings and subsequent curation needs as newborn screening programs look to add more molecular sequencing to their programs. We've also talked a lot in the community about the need for a more collaborative environment for newborn screening programs to examine these variants while also being able to link this information back to the biochemical laboratory data as well as any subsequent clinical data sets that are obtained through the newborn screening process. So for the molecular module, we have worked with the newborn screening community, I think particularly the CDC APHL molecular subcommittee to define requirements. And using those defined requirements have developed both a user interface and much of the back end for the molecular module. Not surprisingly, we've had to be a bit flexible in our pilot testing through the pandemic. But we have completed a first round of pilot tests with several newborn screening programs. We've incorporated that feedback into the build and have actually just finished onboarding pilot sites into SAMS so that we can do a more thorough second pilot test. So right now, our variant interpretation module, or this molecular module, really starts at the point where programs have identified a variant in one of the genes associated with newborn screening conditions. And the user interface is currently able to accept kind of common variant file types, so VCF and CSV files. It does offer a standardized module for collaborative interpretation of variants across newborn screening programs, and probably most importantly, in especially a high throughput environment, EDN utilizes a variety of APIs or application programming interfaces to really pull the evidence of pathogenicity needed for variant interpretation, so that all of this information, all of the evidence, all of the interpretation, and then the subsequent documentation of the variant and interpretation can occur in one location, which is EDN. So as I indicated on the last slide, when we first began our development of EDN, we started from the point of programs kind of having done their sequencing and having identified any variants. So really at that point of having a variant call file. What this meant was that the EDN platform was coming kind of a bit downstream of the complete sequencing workflow. And as we continued to work with programs through discussions and through pilot testing, it became clear that the upstream sequencing, alignment, and variant identification process could also really use assistance and automation as well to aid in newborn screening programs' ability to add this type of testing and interpretation. And so understanding this, we embarked kind of on a side project, an additional project with EDN, with CDC's Office of Advanced Molecular Detection. And we're going to be working with an offering that they have known as LIMS Lite, which, when we connect this LIMS Lite to EDN, will allow us to provide really an end-to-end molecular workflow for newborn screening programs, and really thinking through having the centralized resource and how it will help us address our current issues of siloed and really kind of highly disparate bioinformatics capabilities across state newborn screening programs. So we're really excited about this idea of expanding EDN to provide, again, just a complete workflow for newborn screening programs who are looking to do sequencing within their program. So as I kind of just described, this is a schematic of what we have been talking about. So when this project is complete, we intend to have an end-to-end solution for newborn screening programs. And this schematic gives kind of a high level overview, of the workflow. So if we start on the left, newborn screening programs would provide de-identified sample metadata from their LIMS so that we can link data coming from the sequencer, of course, to the correct specimen or patient. That's very important. This data would be ingested into the LIMS Lite platform for data management, reference genome alignment, analysis, and variant identification. So once from there, a variant call file is created, this would then be sent over to EDN, where newborn screening program staff can go in and complete their variant interpretation, examine interpretations of the same variant from other programs, and ultimately obtain a final consensus variant report for sending out to patients and providers. Of course, we certainly recognize the importance of this work to not be siloed and to contribute certainly to the broader clinical genetics community. So we are currently working with Mastermind Genomenon to assist in the literature and variant curation piece, and also absolutely intend to contribute variant data to ClinVar. And this really presents an opportunity to work with MBSTRN as well on kind of ongoing variant annotation and curation as well. So though I'm presenting or talking about the clinical module last, it is perhaps one of the most important pieces of EDN is really having this robust diagnostic data is crucial to building our analytical algorithms, assessing the success of newborn screening, and certainly contributing to new knowledge discovery in rare disease. So not surprisingly, this is an area where a number of challenges have been identified. by newborn screening programs, both in terms of a generalized lack of standardization and diagnostic data elements that are being collected across newborn screening programs, as well as the difficulty in getting this information from the medical system. And again, with a lot of clinical data that's coming in through the follow-up process, there's often a lack of connection of this information with the newborn screening laboratory data, both biochemical and molecular. And so we're really looking forward to providing this kind of holistic view of newborn screening patients through the EDEN project. So in addition, of course, to our ongoing development of the 3 modules, there are a number of other considerations and next steps that we wanted to highlight for us on this project as well. So the first, of course, is to think through how best to capture this information, both in terms of data transfer mechanisms, but also in terms of the use of standard terminology. So to address this, and I'll get into this in a little bit on additional slides, we've been building off of a newborn screening common data model that was originally put together by Dave Jones. He is now at CDC OAMD, but he did this work while at the Utah Newborn Screening Program. And this common data model looks at the utilization of standard terminology to make downstream analysis a lot easier and a lot more consistent. So using standard terminologies like HPO, or the human phenotype ontology, SNOMED, especially for clinical and diagnostic information, and then LOINC, particularly for lab testing orders and results. We're also looking, of course, to utilize standard messaging protocols, specifically HL7 and FHIR. If we think back to the workflow diagram, we're talking about getting a lot of data. We're talking about needing to get this data in a pretty near real-time manner. And so utilizing these standard messaging is going to be crucial above and beyond our ability to ingest this information in a manual way. So we have been working as well, thinking through how we can keep the burden as low as possible on newborn screening programs. So working with some of the common newborn screening program LIMS or case management system vendors, so that they're aware of this project as well and can help us ensure the ability for that automatic bidirectional data transfer. So on the last slide, I mentioned the use of a common data model, and I do just want to take a little bit of time to talk through kind of what that is exactly. So a common data model is a tool that is used when there is a need to exchange or share a set of data for some particular purpose. And really common data models in public health, in healthcare research, have proven themselves to be really vital components of collaboration that include or involve numerous organizations. The reason why this is so important is that a common data model standardizes and thus really facilitates the exchange, pooling, or sharing of data from multiple sources. So why do we need to think about common data models in the context of newborn screening? I think surprising, probably no one listening today, if we assess the current landscape of newborn screening data across the country, we really find ourselves in this vast kind of sea of variability, both between and even within newborn screening programs. So amongst newborn screening programs, there is certainly variability in not only what data elements are collected, but what the data elements are called, how the data elements are collected, how they are stored, and how or if they are kind of reported out. So I pulled an example. If we look at what I think many of us would think would be a relatively simple data element example, so gestational age, we can see that, first of all, not all programs collect this information. And when they do, they may collect and store it in several different ways, some with the decimal point, some truncated, without the decimal point, kind of on and on. And so I know many of us have all heard the saying, if you've seen one newborn screening program, you've seen one newborn screening program, which unfortunately really also holds true when it comes to newborn screening data as well. And this has several important repercussions and is something that we're really committed to working towards so that we can all contribute and aggregate our data more seamlessly within Eden. So this slide indicates what a common data model looks like in action. So here we can see on the left side that we start with various data sources. In this case, it's likely to be various newborn screening programs. This data can be extracted and harmonized into the common data model utilizing the standards that I discussed on an earlier slide. And doing this, having this agreed upon model for data structure and transfer allows for a number of really important outcomes, including the ability to more easily share and aggregate data, which in turn allows for the use of more robust data analytics, including more powerful machine learning models, and really overall better collaboration across the country in using newborn screening data to improve detection and understanding. So I want to start to kind of wrap up and end with a quick note on data security and privacy, as we really at CDC understand how important this is to the transparency and trust of this project. So these are concepts, data privacy, data security, that we have really talked about and discussed since the beginning of this project, and are working to align with global standards such as the Global Alliance for Genomics and Health, their regulatory and ethics work, but really thinking through just how we can set the standard around regulation, governance, and ethics with the transfer and use of this data. So if we think from a data security standpoint, again, looking at utilizing secure cloud infrastructure, we will have managed and role-based access. And then again, using that SAMS authentication, will have identity and access management as well, so that only those individuals who need this information and who have the right and are authorized to this information will have access. And if we think about data privacy, there's a number of components that we're working on in this respect. So we will have all states sign data use agreements. We have done internal data privacy impact assessments. We're also working on an assurance of confidentiality, but really also ensuring that we set the tone in terms of transparency of how this data is being used, what's going into the models and algorithms, accountability on both parts, and ongoing regulatory and ethics reviews. So I hope that you can see that this really is a long-term passion project for us that we feel has the potential to really drive newborn screening data modernization by providing the infrastructure to aggregate data across the country, provide robust analytic solutions to all newborn screening programs, regardless of their resource capabilities, and ultimately improve our ability to identify at-risk newborns and assess health outcomes in newborn screening. So with that, I again want to say thank you so much for the opportunity to share this project with you today. And both Carla and I look forward to taking any comments or questions.